Hello, everyone. Thanks for joining us again for another session on our platform. It's a pleasure to host my colleague and friend, Dr. Najib Tecle. It's his third time on this platform. The reason is he's one of the best speakers I've ever listened to and always thinks outside the box. So again, Najib is an assistant professor of neurological surgery at Northwestern, and he specializes in treating every single spinal pathology that exists, from minimal invasive techniques up to deformity corrections, unblocked spondylectomies, CVJ disorders. In addition to that, he has an MBA, so he's also an entrepreneur, he's an engineer, and he also is an educator. He's the associate program director. So without further ado, I'm going to have Najib start speaking. And the topic today is very inspirational. It's to everybody interested in pursuing a career in spinal surgery. So he's gonna make this the topic of this presentation, and he'll drive it home. So without further ado, again, Najib, thanks for coming and joining us this evening.
Thank you for the introduction, Nader, and it's great to be back. Let me share and get started. Okay, well, I wanted to talk about today, what I wanted to talk about today is spine surgery is cooler than brain surgery. And a while back, I was doing a seminar on how to do an engaging presentation. And part of the process was if you manage to challenge or offend your audience when you're starting, you get them to pay attention. But that's not the reason that's the title of this presentation. The reason that this is the title of this presentation is simply because it's true. And if you don't believe me, actually, it's all over the internet. If you go on the AANS website, you get like the fathers of neurosurgery documenting that spine surgery is cooler than brain surgery. Now, some of you might say, oh, don't believe everything you see online and don't believe the internet. It's a conspiracy theory, but it's not. Now, let me tell you a little bit more about spine surgery. In a way, modern spine surgery is no longer what it used to be. So let's say you're interested in microsurgery. The world of intradural pathology has everything that microsurgery has to offer. In this hemangioblastoma, this is the classic sunset orange appearance. You get to do all the microsurgery you want. You're going to be dissecting that hemangioblastoma, identifying the feeding arteries, the draining veins, the same way you do as an AVM. You're getting your preoperative angiogram, you're going to get your intraoperative ICG, and you're going to work on that hemangioblastoma in a way, one vessel at a time, trying to really do some good microvascular dissection. If there's a vessel you're worried about, you're going to clip the vessel, get your neuromonitoring signals, and then if there are no changes, you're going to sacrifice the vessel, and eventually that hemangioblastoma is going to be out. You're going to leave the draining vein till last. You're going to take that out, and the hemangioblastoma is out. And in this patient who has a huge syrinx at the conus at presentation, that's the MRI just 6 weeks after surgery. More into the world of intradural pathology, there's this leptomeningeal cyst, there's this schwannoma, great simple surgeries. You're going to do your laminoplasty up top. This has multiple videos for the TikTok generation, so you're going to be repairing that leak there, and you're going to take out that schwannoma, some microsurgical technique where you can do whatever a cranial surgeon can do. But beyond intradural pathology, let's say you're interested in skull base, you're going to encounter pathologies like these, where in this patient with a retrodontoid pannus that is rapidly worsening, you don't have the luxury of time to do a fusion and wait for the pannus to go away. In her, what I did was a transcervical odontoidectomy, and you get to do that. You fuse her from the back. And these are some of the only cases where I still do rotisserie. You're going to see here the entire OR showing up to get the rotisserie done, because simply it's one of few cases where you're destabilizing the spine so much that you need to do something like that. Now, let's say you're not into that stuff and you enjoy lateral approaches. That's a thoracic disc, where you all know in the good old days what we would do for something like that. Big surgery, whether it's lateral or posterior, Now we can do it in a way simpler, less invasive technique. You can see we have barely any rib resection here, and we come in laterally. We're gonna do a small corpectomy, push that thoracic disc, and the disc is out. Now, if you're not much into lungs and you're more into bowels, the world of lateral approaches moves south with you. And in this patient with burst fracture at L3, you can also, using a 1-inch incision, do this corpectomy. And as you're doing these corpectomies, if you're like, well, I enjoy these surgeries more in a sitting position, you can also go for prone lateral approaches and do these surgeries in a PTP fashion. Now, let's say you're not much into anatomy, but you're more into technology. We have robotics to offer you. So you're going to be able to do robotics, and you're going to be able to do things like this minimally invasive TLIF, where you're relying on your robot for navigation, and you're going to be able to place the screw exactly where it's planned. And if robotics is not your thing, maybe your best number, your favorite number is 2808-1980. That's Dr. Dadali's birthday, by the way. That's the ICD-10 for titanium deficiency. And you like to put a lot of titanium in patients. Then we have deformity for you. And just what deformity is, again, a primer for those who are more cranial inclined, it's putting the head out of balance where there's a lot of pressure on your low back. What I tell my patients, it's like holding a water bottle close to your body versus putting your hand out and holding that water bottle for a long duration. And for something like that, I've showed these in my previous talk here. So I'm going to show a case. This same case I showed last time. This patient, obviously, his head is sitting out of the cone of economy. He is way to the front. He's already fused. And what you're going to do is you're going to imagine what's going on. You're going to come up with your plan. You're going to say, okay, that's what I'm intending to do. I want to put the patient's head back. And you're going to go and execute that plan. And that's what it will look like in surgery. Of course, you're going to do a quadruple rod construct for an osteotomy. And this is another example where you're also going to imagine what's going on. You're going to try to imagine how the repair is happening in your head before the execution, and you're going to go and execute the plan. But beyond the cool surgery, why is spine surgery really great? First, there's always more to learn, and each of us are going to encounter what's new to us is going to be different from one person to another. For me, it was endoscopy. I graduated residency and fellowship having not done a single endoscopic case. But every time you're approaching something new, there's this idea of a Dunning-Kruger effect. It plots confidence against competence. So initially, when you start the first couple cases, you're going to be like, yay, it's easy. Everything's great. It's so easy. Then all of a sudden, there's this rude awakening of, look, these cases are hard, not that easy. And then eventually you get to that slope of enlightenment where, okay, it's starting to make sense. And then the plateau of sustainability. And endoscopic cases, for those who are not familiar, this is an interlaminar approach. We're getting to that ligamentum flavum. We're opening the ligament. We're kind of mobilizing the nerve. We're going to get on the disc. And that's how fast I operate. That's true. And at this stage, we're going to get that disc out and this coming out, and you're gonna get this in multiple fragments, and eventually that's as close as you get to incisionless spine surgery. Now that's how this happens in the OR. You have your C-arm, you're doing the incision, and then of course when you're doing these cases, for me, I'm not doing much teaching because at the time I was still new to that procedure. But while that's what you see, the reality of what's happening is more like this. So a couple hours into the case, you're thinking, should I still be going with this discectomy? Should I convert? And it takes a long time, and you need to own it and be like, sure, it takes a long time to master a new technique. And it's important to keep track of your outcomes. Those are some of my first 11 cases, and now I'm like 50 cases in. But like here, I had issues. They were returned to the OR. There were cases where I converted to open, a CSF leak. And these are the times where I returned to the lab to do more of these. And eventually, I'd be lying if I tell you there are cases where I don't convert and things like that. Sure, it has gotten easier, but some cases I still convert, duct my tube in and do these cases microscopically. Now, beyond the opportunity to learn and remaining engaged during your career, beyond the cool surgery, an exciting future is away. Now, as far as the future of spine surgery is concerned, I had this discussion with ChatGPT. And of course, that's a normal thing to do at 1 a.m. in the morning. Ask ChatGPT, tell me about the future of spine surgery. And I got these 3 pictures. So didn't make much sense in the beginning, but I'll take you through them. Before I get there, though, I was like, how good are we as humans at predicting the future? And apparently we've tried to do this before. In the year 1900, a French artist tried to ask people, what do you think the future, what do you think the year 2000 is gonna look like? And people made all these drawings, and eventually they printed them on cigarettes. And they were imagining what the year 2000 looks like. Now, we can dissect one of these. Let's look at this one. So they're imagining, sure, some robot helping with house chores and things like that. But if we really want to dissect what happened, they failed to predict that they're going to be a TV, right? They failed to predict that they're going to be computers and remote work and things like that. Failed to predict the AirPods, iPad, all that stuff. Of course, they imagined some robots. They were way off, though. But most importantly, they failed to predict all the societal changes, everything that's big that happened since the year 1900. And that was really important during the 20th century. Now, which brought me to one of my favorite books. There's this book by Stephen Johnson, Where Good Ideas Come From. He talks about that concept of the adjacent possible, the idea that, look, there's always a set universe of what's we're capable of imagining next, what we're capable of inventing next. He gives that idea that in the year 1600, there's no way someone could have invented the microwave because there are so many parts that needed to be invented before the microwave was in that world of the adjacent possible. And similarly, when we're going to talk about the future of spine surgery, it's going to be pretty similar. There are things that have now become accessible to us that were not accessible even 10 years ago. I'll go back to that discussion with ChatGPT. And while we may not be able to predict the future, we can for sure create it. So I'll start with the first picture. And to me, analyzing that picture, it's more of an AR, VR type picture. There's a surgeon doing surgery, but that is augmented by certain additional technology. And if we look at what we're currently doing at Northwestern, I can show you this. You're familiar with the Apple Vision Pro, and that's one surgery done with the Apple Vision Pro. And I'll show you what that looks like. When we're starting here, it's looking at it from the outside, it looks pretty weird and unusual. And the people working with you in the OR are like, okay, what is that guy doing? Pretty funny, unusual. And again, this is one of those things where like it looks like it doesn't make any sense. But let's go to what's really happening on the inside. That's the inside. Let's try again. So that's what's happening on the inside. And so what you have access to is going to be those patient scans that you can put anywhere you want in the operating room. The patient's previous hardware that you also can put anywhere you want in the operating room. And of course, the patient's imaging that you can load and put in front of you, where you have access to all these screens. At this stage, sure, you're putting them across from you, but nothing would prevent you from putting them in the patient and correlating that with the patient's anatomy and the patient's alignment. Now here we're rodding the patient. And you may wonder, why is this important? Why do we need this? One, we need it for teaching. As you can imagine, this is probably better than most videos in the sense of what you're capturing. Of course, here it's running so fast, so not that helpful, but we need it for teaching, but we also need it for the future of surgery. What I mean to say here is, if you think of autonomous cars, they need their billions of miles of training. If this here is ever going to become your surgeon, they will need those billions of hours of surgery. And capturing surgery that way is what's going to make those miles available to train the AI model that's going to make surgeons look like that down the road. Which brings me to the next point. That was the next picture generated by ChatGPT. And to me, that's automation. There's no surgeon in this picture. In this picture, there are robots operating on a human being, and that's happening without the presence of another human being in this room. And this brings me to work that I've done with Andy Hall's lab in St. Louis, where this is what we're doing, placing a pedicle screw without human intervention. That's the robot going in there and putting the pedicle screw in. And of course, this is not spine surgery, but this is an idea of what's going to be possible over the next 10, 20 years, right? We're not saying that, oh, if you're able to put the pedicle screw, you're able to do independent spine surgery. But that's the concept of automation, where the robot is capable of doing it. But more importantly than the robot, there's the AI that's doing the work. And this is where we started a new work of building a data set. And to build a data set, you can go complex and be like, I'm going to label this entire surgery that is quite complicated. What's fortunate in our case today is that endoscopic surgery is very computer friendly. An L5-S1 microdiscectomy, you take those pictures from the endoscope, that's all you need to label. So we started this data set. And we're labeling every single frame coming out from the endoscope with the hope of training an AI that is going to understand what's happening in surgery, and eventually that is going to hopefully be able to perform the surgery. Now, we're not there yet, but that's how we're starting. As we build that data set, we hopefully will get there. Now brings me to the third picture. I did talk about this last time, but our scoliosis tissue bank is ongoing. We're just now starting to collect those biological specimens, where the future of spine surgery may be biological, maybe biodesign. It may be a pill or a virus or a DNA vector or something of the sort that is gonna take over the spine surgery world. We go back to this thing of, well, what's beyond cool surgeries? And like, those are the surgeries we talked about. We talked about the future being great. But beyond that, it's all about the people. And the people, it starts with the people we treat. What I tell residents is that in spine surgery, we're in the business of life expectancy and life expectation, meaning the business of quality of life. We're the people we touch, the people that undergo spine surgery are getting their lives back. And that's what makes this field very rewarding. But also, more than the people we treat, it's the people we work with. I'm happy to be part of this wonderful department at Northwestern, where we have a lot of great people. And beyond the people we work with, there's the spine community, where all of you are part of this wonderful community, where people are fun to be around, people are fun to work with. And I want to conclude. I know it's a short talk, but I want to conclude with the following. Quotes like this were not unusual about spine surgery in the 1990s. And I'm not going to read them, but if you want to read them, in a way, maybe these quotes were common because they were true at the time. Maybe spine surgery of the time wasn't spine surgery of today, but spine surgery has definitely evolved significantly over the past couple decades. Which brings me back to my conversation with ChatGPT about like, I asked ChatGPT, tell me about spine surgery and make up a joke about spine surgery. And it said, if brain surgery and rocket science were to have a child, it would be spine surgery. So it's not rocket surgery, but it's spine surgery. Thank you all for listening. I'm happy to answer any questions.
Thank you so much, Najib, for a spectacular talk. Supremely inspirational. I mean, each case that you presented is just maybe it needs a separate seminar on its own. But it's just a fantastic overview of what we can offer for our patients, how bright the future is. You know, what would you advise? I mean, always, you know, when I think about these presentation, I always think about the context of training and trainees. Obviously, training the future generation of spine surgeons, and what would you advise someone who's finishing up his training or fellowship, embarking on a career in spinal surgery? Two important pieces of advice that you would give that human being. What would they be to you know, to help him or her maximize their potential as a spine surgeon, as a human being, as a contributor to society?
Great question. I think there are like two, in a way, spectrums of where that goes. One is, as a surgeon in general, stay humble. If you're not humble, surgery will humble you, because there are gonna be those cases, regardless of what you do, that you're not gonna be able to achieve what you're hoping to do. Now, on the other hand, also stay curious, because only curiosity, only that you wanting to know more, whether it is through research, whether it is through developing your technical skills, that's how you're going to advance the field. So stay curious and stay humble.
Excellent. Alex, thanks always for joining. What questions do you have for Dr. Tecle? And also, we're opening up for our audience as well through the chat box.
Yeah, I really enjoyed, Najib, your talk. It is always so important to look back, and gladly you didn't mention the name of the surgeons who did these historical quotes. I guess maybe it was my teacher because I remember it a lot. I think the look into the future is really difficult, but you are absolutely right. We can create the future. I wonder, when you see the surgery again with your virtual reality glasses, if you look back to this surgery, do you really think that AI will learn from this point of view, or is it more that AI will go a completely different approach, a completely different way, or is he mimicking our approach, or do they go a different way? What do you think? You are doing great deformity surgery and endoscopic surgery as well, like from max to minimum. What will AI do? Choose one of these ways or find a different way?
It's pretty interesting to think about it, because there's this concept in AI research that's called transcendence, meaning if you take a data set and train an AI model, regardless of the model details, on that data set, can AI perform better than what the data set shows? And actually, just a couple months ago, there was this paper about where they trained AI on a bunch of chess players whose like score was 1500, which is like an average score. And the AI model was able to outperform the 1500 score, get higher score, because it learned from every single player. So now, I think still, at least in the beginning, maybe next 50, 100 years, that concept of transcendence is not going to be there. But eventually, who knows? Maybe they'll have way better ways of doing things than we have today. But I think transcendence may be happening just like in AI research in general. Who knows? I'm excited to see what the future holds. And I wish I had the answer. But it's one of those things where like looking for it makes it interesting.
Yeah, I think when you do endoscopic surgery and you have shown so clear views, like everything is under fluid and there's no erythrocyte at all. But you know, I do endoscopic spine surgery and I have got this read out. Will, or can you imagine that anybody that else than a human being will be able to solve these situations and make a decision what to do when there's nothing to see?
Yeah, exactly. But if you look at the automation videos of cars where they're doing things humans would never do and like saving lives, and if you look at self-landing rockets and things like that, I don't know. Maybe one day they'll be better than us. Maybe one day, like the safety, when counseling a patient, you'll be like, oh, you have the option of a human surgeon, rate of error is like 8%, AI surgeon 6%, and it would be like unethical to choose the human surgeon. I don't know where that's gonna go. I think, but if it's gonna get there, it's gonna be us, like as spine surgeons, who are gonna build it, right? It's not gonna happen through the industry. Can't develop a robot that does that. It's gonna be surgeons. And ideally, Dr. Dadali always talks about having a robot do the surgery while he's writing papers in his office. Maybe one day we'll get there.
Fingers crossed. I mean, that'll be a dream come true. Now, so there are a couple of questions in the chat box since we have time. The first one is from Triva T. Dr. Tecle, with our exploding aging populations, we are lacking in spine surgeons for the increasing demands of patient care. How would you use AI to increase more medical school residence fellowship openings?
It's interesting in the sense that, look, the Gen AI can help with the knowledge. When we talk about surgical training, a lot of it is the surgery, right? So if we can have somehow AI help us refine our simulators and things like that, where surgery can become something that's like pretty really simulating what's happening in surgery, where you can't tell if this is surgery or simulation, things like that. I don't think we're even close, but if we get to that point where simulators get so close to reality, maybe you can do things like that. Currently, what we have is, sure, you can talk with ChatGPT and then learn more about a microdiscectomy, and sure, there'll be tons of errors in there, but you can train a subset of ChatGPT on, say, the neurosurgical textbooks, the orthopedic textbooks, and try to get more accurate information. But still, I think the key with surgical training is the surgery. You need your reps. You need to do real surgery for you to become a real surgeon.
Yeah, I think, yeah, I totally agree. You need to do the reps. The more you do, the better you become. However, you know, a couple of things, like I think of vascular neurosurgery. Now we're digressing a little bit away from spine, but maybe this maybe applies to, like, for instance, en bloc spondylectomies. Like, these are rare cases, and I think the utility of simulators, those perfect simulators, probably generated by AI, collecting data from excellent surgeons, and, you know, putting together a perfect simulator would tremendously help in rare you know, in those situations where, like, most people are doing endovascular instead of open, yet you still need to do that rare open case for a very difficult aneurysm. So that, I think that's what can come into play. Plus, surgical videos are really important. Perhaps AI can provide the best surgical video, right? Like a flawless, because you observe those videos and you can, they're very helpful. It's, you know, it's definitely inferior than doing it live, but still you learn so much from those surgical videos. Oftentimes they're not necessarily fantastic, but perhaps AI can put together that perfect surgical video demonstrating a case, a difficult case. Another question is by Laura. Thank you so much for the presentation. I was particularly interested in the use of endoscopic techniques. How do you record any complications that may arise? And number two, she's working on a project. Can we collaborate? Number three, what's your how can I get in touch with you?
Absolutely. I'll send Laura here my email in the chat, on the private chat. And I record complications by, like, I keep track of all these cases because they were new to me. Epic makes it, the EHR makes it way easier to keep track of all your cases. So that's one of those things where you can query your electronic health records and get the cases you've done as a surgeon. But I've been keeping track because I've been particularly interested in seeing if I'm performing the same. If I'm doing a disservice to my patient, in that case, I would stop. Or if my patients are doing better than with just regular MIS technique. So I've been keeping track of those, like just plain Excel sheet and just tracking these complications.
Spectacular.
Najib, may I ask you a question?
Absolutely.
When you look back, when you started with neurosurgery or with spine surgery, so for me, it's like more than 22 years ago, the OR was pretty empty. Of course, we had a microscope, and our instruments, our surgical instruments were, yeah, at least we used like 20 different. When I now go into my OR, it's completely overstuffed with technical devices, huge monitors, a lot of visualizations. You see the robot here, it's coming. We have so many cables, wires, devices. When you start with spine surgery, do you think you will manage to oversee all this equipment, or is this a little bit frightening? For me, it was step by step. Every 2 years, a new technology came up, and the room was filled, and I was able to learn, and still I'm able, or I'm a need to learn what is this device for. But what is your impression when the residents enter the room? Are they overwhelmed, or are they going with an intuitivity? Is this normal? Is this easy for them?
I wouldn't say it's easy, but it's normal for them. And it reminds me of just an interaction I had this past year with a resident, like a PGY2 rotating on spine surgery. Happens to be with me first with, he was there for like a MIS discectomy. Then he came back the next time and he was trying to set up the room, but he realized, oh, this is an endoscopic discectomy, interlaminar discectomy. Comes in the third time, it's transforaminal discectomy, and the guy is completely lost. Like, what's happening in here? And he was like, I've seen 3 discectomies, none of them look like the other. And I think there is that, yes, the more we're doing, the more people are lost. And I tell the residents, look, we go back to the basics, the anatomy, all that stuff. You need to understand first the big open surgery where you have full visualization of the anatomy. But yes, I think there's an overwhelming component to it where like all these things, robot, navigation, and then if you're doing what navigation you're using like you're spinning, getting a CT scan, you're using your pre-op CT scan, doing a LiDAR style navigation, all these things may get overwhelming for the residents but I feel for them it's like for us when it's happened like over time, but it's happening in a more condensed version of time where sure over there PGY2 through PGY7 they're getting exposed to all these other things, and eventually like they work with a small subset of attendings. So we all have our preferences, and realistically no one is using all the technologies in the world, right? So they get used to what their attendings do, and eventually that's why I encourage people to go and do fellowships at different programs, just because you will invariably learn something different, something new from seeing other people's perspective.
Yeah. Thank you. Nara, may I ask you, when you look back, when you started 2004 or something, the OR, was it an empty OR or was it already filled with technology at time?
Oh, certainly. So I started residency in 2005, and then, through residency, I remember the first time we got the OR, we tried it on ACDF back in Iowa, and it was one of the first institutions to acquire the OR. Absolutely, there has been an nearly exponential increase in the amount of variety of tools and equipment, explosion in navigation, and now endoscopy. Like doing a micro disc, and you need the C-arm, and you need a microscope, and you need your tools. So even if it's a small case, you need so many different things. And in the past, you do it open, using loops, right? Like now, right? Like, so I've noted over time throughout residency, fellowship, and then now that you have the number of reps, 1 to 2 reps, have increased, and that's a good thing. Some things did not persist. Some things did not really prove the test of time and has fallen off. But for the most part, we still see a steady increase of personnel, reflecting the need, reflecting the increased variety of technological opportunities available in the operating room. Endoscopy is new. Like in the past, like that's the thing. That's why you need to stay, seek your education. Education doesn't end with the end of residency, right? Like you got to continue going to courses, improving yourself as a surgeon to offer the best possible treatments for your patients. You can't just stagnate. So Najib, right away, right after he finished his fellowship, we don't, at Northwestern, we don't train fellows with neuroendoscopy or spinal endoscopy. So he right away acquired it, went to courses. A lot of hard work. It's a lot of time and effort and videos and courses. And you got to try that first case in the OR. That also takes guts, right? Like getting through that learning curve. So that's an important point I want to emphasize, is that with the end of residency, education should continue. Self-improvement, reading books, looking at videos, just becoming better and better, and shouldn't end at any age, in my opinion. It's a source of happiness and satisfaction as a human being, just to continue learning, and that should never stop, even at the age of 65. It should never stop. Like that's my opinion.
Thank you. Yeah, I think it's funny. I was in neurosurgery and then I switched to orthopedic surgery. And in orthopedic surgery, we also had this discussion: why is spine the coolest part of orthopedic surgery? But I think the most important thing is what what Najib told us. You get so humble in spine surgery, and this is quite a little bit of difference to trauma surgery. They get humble as well. When you see the amount of patients who die in polytrauma, you know it from neurosurgery. It's really you get humble, but the amount of happy patients you never see again is a lot higher in other specialties than spine surgery. It is the coolest specialty, I agree. But also, spine surgery is that part of orthopedic surgery, that subspecialty with many patients you see for a long time, still, yes, thankful, but still unlucky, unhappy with their situation. And this is what you don't have in hip surgery, the same when you do arthroplasty, when you do the osteosynthesis. It's very, very high chance that the patient gets happy, like 90, 95%. Like ACDFs, a lot of ACDFs, this is hip surgery. And I think spine surgery has some negative parts as well. I just want to mention this in this point of this session. Cool, yes, but it's also very exhausting. And on the negative aspect, we have some. I have some drawers with unhappy patients. And I just wanted to add this to have an honest view when young residents are watching this session.
Oh, absolutely. I mean, and I'll have Najib also comment. It's humbling, you know, because when you're dealing with pain and functionality, right? Like it's not like a resecting a brain tumor. You know, it needs to come out, and there are certain, you know, risks and potential complications. Here, patient comes in most of the time with a pain or with a deficit. The expectations very high. The expectations are very high, right? Like, so you can deal with definitely some challenging situations where, you know, the outcome is not as you hoped for, or you thought the pain generator is a certain location, it turns out to be a different location. Although you got to be compulsive about like localizing where the pain or the deficit is coming from, so you can treat it appropriately. Absolutely, it's a very back pain is a very common pathology. The expectations are always high from patients, as they should be. Najib, any other comments?
No, that's definitely something that the moment you start practicing as a spine surgeon, you're gonna have this wide spectrum of patients who are very happy, patients that are keep coming back, and I guess they call it back surgery for a reason. Patients always come back, but it's I feel with better experience, patient selection, all that stuff, we can optimize for those patients who are going to benefit the most from our surgeries. But there are always going to be those patients who, for reasons that I believe we don't really understand as a spine surgery community, and that maybe with research over the next decade or couple decades, we'll be able to understand. They're coming back, they're not satisfied with their surgeries, and I believe it's our job to help figure this out over the next 10, 20 years.
So yeah, they're thanking us in the chat box. I'm gonna just say thank you so much for joining us.
Last thing I want to ask Najib is, 20 years ago, Apple was not present in the OR. Which companies do you see in 20 years in the OR dealing with us? Will Jeff Bezos or Google, what companies will we have there? What do you think? Just an outlook.
I don't know. Maybe like Amazon will have one of those things where like the day before or the night before you order on Amazon Prime, you get all your pre-measured screws and rods and
overnight shipping. Yeah.
Awesome.
We'll see.
We'll see. Okay, beautiful. This video will be uploaded on YouTube, so for those who missed it, they will be able to access it and also give us some feedback. Thank you again, Najib. We'll be hosting you next week. Just kidding. Yeah. So do you know, Alex, who are we? What's the schedule? Who's hosting who next week? Are we?
No, I'm looking forward to see it on Twitter, on X, on social media. I actually don't know next week.
Sounds good. We'll definitely know in the next few days. We'll put the flyer. Thank you, everybody, for joining us. And specific thanks for Najib as well as Alex. And we'll see you guys soon. Have a good night.
Have a good night, everyone.
Good night.